Namaste. A very warm welcome to all of you to this special session of AMR Dialogues hosted by Global AMR Media Alliance along with its national and subnational chapters and partners on the theme AMR under Gender Lens. Today's session is being held ahead of International Women's Day, ahead of the 70th session of the UN Commission on Status of Women or CSW 70, ahead of World Water Day and World TB Day, which will be later this month. A few quick housekeeping announcements before we begin. Participants, please type in your questions in the chat box even as the speakers present. We will take up as many relevant questions as time permits after all the speakers have presented. Friends, we know that despite promises made by all our governments for health and gender equality, that is what SDG 3 and SDG 5 say, we are not on track. Less than 58 months are left to keep these promises, but the sense of urgency and purpose is seldom seen when it comes to human right to health and gender equality, both of which are fundamental human rights and are inextricably linked. We cannot dislocate right to health from gender equality. Antimicrobial resistance, or AMR as we call it, is caused by misuse and overuse of medicines in human health sector, animal health and livestock sector, food and agriculture sector, and it is also polluting our environment. We cannot afford any misuse and overuse of medicines in any sector if we are to deliver on SDG 3. A complex mix of biological, social, cultural, and economic factors arising from gender based inequalities and injustices impact infection prevention and control. For example, the lived experience of girls and women and gender diverse communities show how violence had put them at risk of getting infected or got them infected with sexually transmitted infections, HIV, or have caused unplanned pregnancies. Gender inequalities, harmful gender norms, stereotypes, and tropes have normalized the neglect of health and well being of girls and women, making them more vulnerable to AMR. It is no surprise that girls and women and gender diverse communities often slip to the last priority when it comes to disease screening or diagnostics, treatment, care, and support. And this is when girls and women are themselves the primary caregivers. Gender based violence is a gross human rights violation, but progress is abysmally low in reducing gender based violence. In the last 26 years, the annual decline is a mere 0.2%. How can this be acceptable? It should have, it means gender based violence should have become history by now. And yet, this low rate of decline. In Afghanistan earlier this year, the government legalized domestic violence so far as the bone is not broken. Should we be grateful that our bones will not be broken? Or should we be outraged that why women beating is accepted by law? Women want to end all forms of violence against them, including emotional or psychological violence. We want to live with rights and dignity and allow the same for all gender diverse peoples everywhere. Ending all forms of violence against women and girls and gender diverse peoples, ending gender inequalities and injustices, ending ageism are not only human rights imperatives but also enablers to improve health responses like those of AMR. We cannot let gender equality slip off the radar if we have to prevent AMR and save our medicines that protect us. Let us hope that governments and civil society leaders who meet at the 70th session of the UN Commission on the Status of Women in New York advance concrete progress towards ending violence against women and girls and gender diverse communities, ending gender inequality, and accelerating progress towards SDG 3 and SDG 5 by 2030. Likewise, water, sanitation, and hygiene is critically important as a human right as well as if we are to prevent AMR. With World TB Day coming up, and also as someone from the country with the highest TB burden worldwide, I would like to draw your attention to drug resistant forms of TB. In the year 2000, the upper end estimates showed that we had around 400,000 cases of drug resistant tuberculosis. In 2024, we also had a similar number of people with drug resistant TB. No change. We have failed down the line to prevent drug resistant tuberculosis as the TB bacteria continues to become resistant because of overuse, underuse, or misuse of TB medicines. And to top it all, we were able to diagnose and treat only 1/3 of those estimated to have drug resistant tuberculosis in 2024, as per the WHO Global TB Report of 2025. We can do better. We could have done better years back. We had the science, tools, and evidence to do so, but we could not. If we are to end TB, we have to ensure zero drug resistant TB that occurs due to failure of infection prevention or control or misuse, overuse, or underuse of TB medicines. AMR and other health responses must have a feminist response, which warrants a development justice model based on care and solidarity for each other, where no one is left behind in the truest sense of the words. In 2024, the WHO released its guidance on addressing gender inequalities in national action plans on antimicrobial resistance. And this guidance provides practical recommendations for countries to integrate gender responsive approaches into AMR policies by addressing key gender disparities in the prevention, diagnosis, and treatment of drug resistant infections. Dr. Sarah Pauline Deschamps from the WHO AMR Department, Geneva, Switzerland, and a senior member of the team that prepared this WHO guidance, was supposed to join us today as a speaker, but could not do so at the last moment due to the conflict situation in the Middle Eastern region. Let us hope peace and sanity prevails, which is so central to ensuring that we deliver on SDGs and other promises. Now, without any further ado, for today's opening address, I welcome and invite my friend, mentor, and guide, Dr. Soumya Swaminathan. Dr. Swaminathan serves as chairperson of MS Swaminathan Research Foundation. She is former chief scientist and former DDG programs of WHO and former secretary, Department of Health Research and Director General, Indian Council of Medical Research. She is a very widely respected scientist and director earlier at National Institute for Research on TB, NIRT of ICMR. Welcome, Soumya. Over to you.
Hello, good afternoon. Can you hear me?
Yes, very clear.
Okay. I'm having a bit of a respiratory infection, so hopefully it won't interfere. Thank you so much, Shobha, for that really excellent introduction to the topic that we are discussing today. At first, it may seem very odd. How do these two things go together? That is gender and antimicrobial resistance or One Health. But when you really start thinking about it or looking deeper into the literature, then you see that there are many ways in which AMR is also gendered. And I must say that anything you look at, in fact, if you look with the right lens, you will find that there are gender-based differences. For example, recently we have looked at the impact of climate change, and particularly the impact of extreme heat on women, and found that most of the reports from India and the neighboring countries show that women are disproportionately impacted whether it's because of worse access to water, access to food, very difficult work and also home conditions where there is no cooling, no ventilation, and an increase in gender-based violence occurring during the hottest months of the year. And over a period of time, when we look at data over the last 10 years, let's say, and we look at NFHS data from the National Family Health Survey, and we overlay that with climatic data. So if we take districts which experienced recurrent droughts in the last 10 years versus all those which did not, and look at some of the health and nutritional indicators for women and children, you find that there are significant differences. So more women are undernourished in the drought-prone districts. More women are married off early, so more chances of teenage pregnancy. There's less antenatal care. There's problems with immunization services. And most significantly, an increase in gender-based violence, probably related to distress, drought-prone areas. There are livelihood concerns and could be more migration and so on. So the point I'm trying to make is that one would think that climate change impacts, everybody the same way. But while it does impact everyone, no doubt, there are certain very unique ways in which women are impacted, and it's very important to understand. So I think the first thing I'd like to say is that this particular topic, very well chosen by Gamma and very relevant for today, and also throws up the lack of data, the lack of disaggregated data, the lack of granular data on this topic. So many of the things that we will talk about today, there's not a whole lot of data really backing it up, and I think we need more focused research in this area. So let's see the ways in which we could relate gender and antimicrobial resistance. And let's start with intimate partner violence or domestic violence that I just mentioned. Obviously, women are at a much greater risk. Most of the time they are, in fact, the victims or receivers of domestic violence. This is physical or could be sexual violence. This obviously could lead to more infections. And because of their position within the household and the community, they are less likely to seek care for these injuries or infections, late care, perhaps those or inadequate care, self-prescriptions, etc. And these could lead to more complicated or drug-resistant infections. So whether it's sexually transmitted infections or urinary tract infections, reproductive tract infections, pelvic inflammatory disease, all of these linked with sexual violence and an increased risk of antibiotic use. Also, quite often in these cases, follow-up is poor. So the woman may go and seek care and then not really follow up. And so she may have taken just a partial course of antibiotics, incomplete or the wrong doses. So it's also true that in emergency settings, antimicrobial stewardship is often poor. When we talk about stewardship in a hospital, generally the hospital authorities look at it in ICUs or post-op wards. There's a protocol for antibiotic use. But in the case of an emergency room, this may not be practiced as thoroughly. And so you may have a lot of misuse of antibiotics going on. And this in turn could, of course, lead to more resistance, whether it's UTIs or Neisseria or mixed anaerobic infections. Clearly also, domestic violence, which as Shobha said, unfortunately, continues to remain unacceptably high, does impact the access to health or other care by the woman. So there's delayed seeking of care, there's because of limited autonomy and also stigma. And so this again would lead to complicated infections and creates a vicious cycle. Now, in terms of antibiotic misuse, in many contexts, women may receive antibiotics without prescriptions. As you know, many of the infections that occur commonly today are diagnosed only based on clinical or what we call a syndromic approach. So there's no diagnostic test that's performed. And there are many such women's health-related diagnostic tests which currently are lacking, particularly in the primary healthcare system. So in the absence of a diagnostic test, it's often the case that a broad-spectrum antibiotic is prescribed. And this could be dispensed by pharmacies without a prescription, or it could even be dispensed by primary care doctors. So while syndromic approach is a pragmatic approach, what it does do is increase antibiotic exposure and may fuel or accelerate development of resistance. And unfortunately, we don't have surveillance at the community level. So the ICMR's AMR surveillance has been expanding over the years, but it's still limited to tertiary care centers, tertiary care hospitals. And so what we get is a picture which is just the tip of the iceberg. We don't know what is going on at the community level. There are very few studies. So again, that's a gap in knowledge that we have. Now, obviously, in humanitarian settings, conflict and displacement, all this gets much worse. We know that women suffer a lot of violence, and it's terrible to see what's going on around the world now. And this, again, will predispose them to infections. Diagnostics are often limited. Antibiotics may either not be available or maybe even used empirically or misused. If you look at healthcare workers, again, majority of healthcare workers, especially frontline workers in the world, are women, and they also face harassment, they face challenges, they face burnout in the workspace, and all of this could also lead to inadequate or weaker infection control practices or antibiotic stewardship practices. Ultimately, the nurses are the ones who really, I think, determine the quality of care across our hospitals and health centers. And so if the nurses themselves are not looked after well, or they're not in good health, or they're not continuously being uptrained and skilled, then you will find that there's a deterioration in the quality of care, and also their own performance metrics. Again, with women who, let's say, are facing an unwanted pregnancy, they go for an abortion, unsafe abortion. In some cases, they are also at higher risk. So there are these biological reasons of menstruation and not having access to sanitary menstrual products, of pregnancy, of childbirth, of abortion. These are all faced only by women, these health conditions. And therefore, all of these, in fact, predispose. If the care is not right, around menstruation, around pregnancy and childbirth, do predispose to higher risk of infections, and therefore the use of antibiotics. And in India, there's a growing threat of gram-negative infections in the case of maternal sepsis. So what we could do in terms of actions, firstly, is to integrate AMR into one-stop crisis centers. So, for example, in a humanitarian setting, or when there's a displacement, there's a flood, there is a refugee camp or for displaced people, and so on. Or even in urban health clinics, for example, AMR, antimicrobial resistance, needs to be integrated so that when there is a situation where, let's say, there is post-violence care needed, then antibiotic stewardship is very much part of the protocol, and there should be some surveillance data capture and evidence-based antibiotic protocols which are relevant for each geographic location. And that you can only do if you have good surveillance data. So the two actually go together. We also need to strengthen diagnostics. So we need to move away from syndromic algorithms towards a more specific STI, test-guided STI management wherever feasible. We have now so many rapid point-of-care diagnostic tests coming up for respiratory infections. Let's take the example of COVID. I mean, within a year, we had so many different kinds of very good, highly sensitive and specific point-of-care tests. The same thing must be applied to genitourinary infections, reproductive tract infections, and urinary tract infections, so that in a primary healthcare setting, we can make a rapid diagnosis and give the appropriate antibiotic. This will minimize costs. It will improve the outcomes, health outcomes, and it will certainly reduce the development of antimicrobial resistance. The other action that could be taken is to include gender-based violence indicators in AMR national action plans. So recognizing that sexual health and violence services are hotspots for antibiotic exposure and include gender-sensitive stewardship indicators. So this is in the AMR National Action Plan. And then, of course, train providers, linking trauma-informed care with national antibiotic use, and address some of the research gaps that I talked about. Like, for example, what's the percentage of resistant STIs among survivors of gender-based violence? What is the pattern of repeated antibiotic exposure in women who experience intimate partner violence? What is AMR burden in those women who have infection after unsafe abortions? So all of this that I've talked about essentially is about how violence against women could be a driver of antimicrobial exposure and equitable resistance risk. And if we look at it from this perspective, it aligns very well, with a One Health approach. And I just want to say a few words about that, because at the MSSRF, of course, we work a lot with women farmers. And as you know, there's been a feminization of agriculture. A lot of the farmers now go to villages. Farming is being done by women, while the men migrate for work. And traditionally, women have always been the ones that looked after livestock and look after poultry or any of the other household animals. They manage manure. They, of course, are also responsible for looking after the children and feeding them, caretaking activities. So when you look at it from an intersectional perspective, that here's a woman, she's also a farmer, let's say a small farmer, who has some livestock and she does some agriculture, and she's in a rural area, and she has a young family to look after, and she's alone because her husband is migrated, and therefore she has less access, to a health center and so on, may have less financial autonomy as well. In such a situation, she would be probably more likely to either neglect infections or take inappropriate treatment. In many parts of the world, we know that people still seek traditional care. And while, for minor things, I think this is okay, but very often we see even things like TB, presenting very late because they've spent a lot of time shopping for treatment, some from traditional care practitioners and others, so from informal health providers who are basically quacks. So any AMR strategy, I think, needs to look from this gendered perspective at the different elements, like, again, somebody who's dealing with livestock, for example, certainly, and manure and things like that, can be exposed to more infection. And we know, for example, even TB is a disease that can spread from human to cattle and cattle to human. In fact, nowadays it's much more common for the cows to get Mycobacterium tuberculosis from their human contacts than the other way around. But again, the data on this is very limited. So we need more data on what are the infections that are going around and what is exposure in rural settings, in agricultural settings, because we know antibiotics are used across the board for crops, for poultry, for livestock, for fish, aquaculture, and so on. So again, it's the non-human sector antibiotic use. And we did a survey across a few districts of Tamil Nadu, and we found that most people, farmers who were using these, had no idea what antibiotic it was, whether it was recommended or not, why they were using it, and what were the precautions to be taken when you use an antibiotic. What is a period for which you need to wait, for example, before you can take the milk of that animal. These were all things which were not, they were not aware of. So we've not done any kind of comprehensive studies to look at exposure to the antibiotic in these settings across all of these different crops, livestock, etc. What is the impact of that on the human beings who interact with them, and whether the use of antibiotics is actually driving antimicrobial resistance in humans. This is something that we need, this pathway of how it impacts is something that still needs to be worked on. So I think I would end by saying that the relationship between antimicrobial resistance and gender is driven by biological factors, by behavioral factors, as well as by things like gender-based violence, taboos, and stigma that occur in society. And we cannot be successful in reducing AMR, but in this case, or preventing more AMR, but in this case also, I would say our equal goal of reducing gender-based violence, as Shobha mentioned in her introductory remarks, and we need to keep speaking up for it, finding the data, putting it out there, and hopefully helping to change policies in the right direction. Thank you very much, Shobha. Back to you.
Thank you, Soumya. Thank you very much for connecting the dots and unpacking how gendered approaches and how gender-based violence makes women more vulnerable to antimicrobial resistance. I'm sure many of us, many of the media persons also, and general public do not see that connect. And thank you for unpacking it so clearly, and also for suggesting concrete solutions, particularly improving diagnostics and healthcare at PHC level, especially for infections like UTIs and others which affect women more. We'll take up the questions later on. There are already a few questions for you, Soumya. We'll take them later. And I now welcome our next speaker, who is like my younger sister, and she is Bhakti Chavan. Bhakti is a member of the WHO Task Force of AMR Survivors. Over to you, Bhakti.
Am I audible?
Yes, you are.
Yeah.
Yes.
Thank you, everyone. Hello, my name is Bhakti Chavan. I am an XDR-TB survivor from India and also a member of WHO Task Force of AMR Survivors. The main function of this task force is to create awareness and humanizing this AMR issue by sharing real-life survivor stories. I would like to sincerely thank CNS and Gamma for organizing this important webinar on AMR through gender lenses. As AMR survivor and being a woman, I would like to connect this issue with the real life experiences, because AMR is not just a scientific concept, it directly impacts lives and especially women's lives. When we talk about misdiagnosis or delay in the diagnosis faced by the women, one of the most common examples is the urinary tract infections. One of my close family members was suffering from the recurrent urinary tract infection. Each time she visited her family doctor, she was advised a routine urine test. The test showed the pus cell and bacteria present. Every time she was prescribed with a new antibiotic course, which was not helping. However, no culture or DST was done initially. Her symptom kept worsening. Eventually, she consulted a urologist. A urine culture and DST was performed, and the result was shocking. The E. coli strain which was found in her urine culture was resistant to most of the powerful antibiotics. Only few were susceptible in her case. Immediately, doctor put her on 1 month targeted antibiotic course and she recovered completely. But only after months of ineffective treatments. According to WHO statistics, 1 in every 6 urinary tract infections are resistant. Because the UTIs are so common in women, symptoms are often treated empirically without proper diagnosis, leading to prolonged suffering and resistant development. Also, reproductive tract infections in women are frequently overlooked because of their symptoms, such as lower abdominal pains, back pain, fatigue, pelvic discomfort, are often normalized as a menstrual pain. This normalization leads to the delay in diagnosis and proper treatment. In many cases, women are advised to tolerate the pain rather than seeking a medical help, resulting in untreated infection that can progress in chronic diseases like pelvic inflammation, infertility, adverse pregnancy outcome, increased vulnerability to other infections. This is all about misdiagnosis and delay in diagnosis faces by women. When we talk about the treatment of AMR, here I would like to connect this with my personal experience. In 2017, I was diagnosed with a drug-resistant tuberculosis. I took 2 years treatment. I was young, unmarried. This 2 years treatment comes with the daily painful injectables and different antibiotics, which I have to take daily. I face side effects like my skin tone changed to reddish brown color. From being a fair girl, my appearance changed completely. I stopped looking into the mirror. I lost huge weight. I was looking like a skeleton. This medicine helped me to recover from the drug-resistant infection, but kept me with a lots of side effects. I carry a scar on my neck because I was diagnosed with the extrapulmonary drug-resistant tuberculosis. The change in physical appearance are not easy to cope up with, especially in societies where appearance is closely judged for the woman. I have seen many women in the patient support group that skips medicine because their visual appearance was changing. We need to support such women who are not confident enough to complete their treatment because it indirectly causing the AMR infections and we are losing on antibiotics. Also, the disease like TB, HIV/AIDS carries a huge stigma in our society, especially for the women. In many communities, a woman diagnosed with TB or HIV is judged not only as a patient but as some who has brought shame to the family. Her character, her marriage prospects, and even her ability to being a good wife, daughter, mother is being questioned. Because of this stigma, I have seen many women hide their illness. They delay testings. They avoid going to the clinics. Some takes medicine secretly. Others stop treatment early to prevent family members or neighbors from finding it out. In case of many HIV women, often blame first, even when they get infected from their spouses. AMR is not a gender neutral. AMR strains are circulating in the environment, and if it can happen to me, it can happen to anyone. If we want to fight AMR effectively, we must listen to the women, diagnose them earlier, ensure proper treatment, support adherence, and design policies that consider women's realities. Thank you.
Thank you very much, Bhakti. Thank you for sharing your lived experience and also mentioning the role of stigma, what stigma plays in delaying access to medicines, in delaying diagnosis for women. Thank you very much, Bhakti, for being there. Moving forward, we have Dr. Esmita Charani, Associate Professor, University of Cape Town, South Africa, and Honorary Reader in Infectious Diseases, AMR, and Global Health, University of Liverpool. Her contribution to WHO guidance on AMR and gender inequalities is well known. Welcome, Esmita. The floor is yours now.
Thank you very much. It's a pleasure to join you. I hope you can all hear me.
Yes, very clearly. Sorry.
Thank you very much, Dr. Shobha. So I am going to talk a little bit about my experience as a pharmacist who started working in research, starting in the UK, but increasingly working in other countries, including India and South Africa, and how through over 15 years of research in looking at how we optimize antibiotic use to reduce and mitigate the risk of antimicrobial resistance, I am more and more convinced that we need to have a social science lens and we need to take an intersectional approach. When we look at the burden of disease in terms of drug-resistant infections, the burden of disease predominantly remains in populations that have the least access to resources, including antibiotics, to be able to treat infections effectively. So I think it's really important to remember and realize that, and to identify what vulnerability looks like in different populations. So a lot of my early research was in the UK, working in hospital settings, looking at how we implement infection prevention and control and antibiotic stewardship interventions to optimize antibiotic use. Now, arguably, the setting in which I was working is one of the more well-resourced settings, because we have National Health Trust hospitals, we had healthcare staff dedicated to infection control and antibiotic stewardship, and most importantly, we had a multidisciplinary approach. So as a pharmacist, I was involved in the processes, nurses are involved, working alongside doctors. In much of the world, this is very different. We still work in very strict hierarchies when it comes to medical practice, particularly in hospital settings. The power differential between the patient, the end user, and the healthcare provider is very strong. And that is impacted by gender. It's impacted by gender norms and roles within society, but also by gender norms and roles within healthcare services. The majority of the healthcare workforce, when it comes to nursing and pharmacy, for example, are female. And then we task them with the expectation to change the behaviors of doctors that predominantly remain male in many settings. And medicine itself is very male-dominated and very hierarchical historically. So these dynamics need to be understood in terms of how we design and develop interventions to optimize antibiotic use. And what is also important to realize is that the power differential between the decision maker and those for whom decisions are made is very different depending on whether you are in the public sector and you are using public services that are for free, whether versus when you are paying as a patient to use services. And we saw this a lot in the work we did in India, how patients in the hospital where we were working was a public-private hospital, and patients who were paying for healthcare services had more say in demanding tests, demanding antibiotics, demanded branded antibiotics. So we need to understand this, and these power dynamics within the family change based on gender identities. In many settings, women often put their own healthcare needs behind those of other family members. Women often have the role of the care provider, unrecognized role, sort of unspoken role of providing care. And what we saw when we've done a lot of research with the hospitals in India is that women would often come in as carers for their family members, not necessarily seeking care themselves. The stigma that other speakers have already spoken with in relation to infections is really, really key and important in terms of accessing healthcare. When there is out-of-pocket expenditure of healthcare, often male family members might be selected over female family members. And we've done a lot of work with Dr. Deepshikha, who's going to speak later about this, and identifying gender norms and roles in society. But one of the quotes I use a lot in my research, which I really like, and this is a quote that was made by Hans Rosling in his book Factfulness, is that the world cannot be understood without numbers. But the world cannot be understood with numbers alone. And we can say the same thing about antibiotic resistance, that antibiotic resistance cannot be managed without new antibiotic and diagnostics, but antibiotic resistance cannot be managed with new antibiotics and diagnostics alone. Because no matter how many agents we bring to the market, no matter how many solutions we bring to the market, if we don't contextualize it, if we don't make it available and accessible to those most vulnerable, we will be in the same step that we are now. We will always have this issue. So why do we need an intersectional lens? Well, because our positionality within society, our fallback within the family, within society, within the community in which we live is very much dependent on gender, but also on religion, on culture, and all of these factors will, on our migration status, on caste, for example, in India, or race and identity in other settings. I work in South Africa now, where there is a difference by ethnicity and race in relation to access to resources, and this is linked to history and injustices that have happened in the past. But what this then decides is our level of access to education, to occupation, to wealth, access to water, hygiene and sanitation, access to healthcare services, including vaccination programs, and all of these layers of privilege decide our ability to be able to have access to interventions such as antibiotics, such as doctors who can prescribe us medicines that we need, but also our representation and policy and decision making, which is really important. So this is the work, the WHO work we did together with colleagues around the world, was exactly this, to identify how we need to bring gender norms into a recognition of the role of gender norms in relation to equity in health, into policy making around antibiotic resistance, but also more widely around antibiotic access to medicines and antibiotics. And I think it's really important not to separate the discussion around access versus excess use of antibiotics. We still need to make sure those that need antibiotics have access to them. And this will be gendered as well as other social norms in different places and different cultures. We did a big piece of work looking at how do social determinants of health influence AMR and antibiotic resistance. And the overwhelming evidence is that, first of all, we need to define social determinants of health in different cultures and countries. And secondly, there are many upstream factors that influence inequity and access to healthcare. And this is very much closely linked to power. So our research that looks at how power is negotiated in the healthcare space has identified that women often have the least power in being able to negotiate, advocate for themselves within the healthcare setting, whether they are healthcare professionals or whether they are patients. There's a lot of evidence around the negative consequence, the negative experience of being a woman in the healthcare system if you are giving birth, if you're going through childbirth, if you are coming to receive healthcare for yourself as opposed to for another family member, and how we need to recognize this and identify how we can leverage power for positive outcomes. There are examples where this has been done when interventions are developed considering the needs of the target audience. A really key example I'm going to give is, for example, there was a study that looked at women not being able to access maternal clinics. And so they created a space, women-only space for women to be able to come to the clinic and access healthcare services. But what that doesn't consider is the access to barrier within the community. Is it the husband? Is it the family members that are not allowing the woman to actually make it to the clinic, to actually arrive and be attended in the clinic in the first place? So we have to understand the gendered roles within society and culture, and not only address the gendered roles within the healthcare system. We have a lot of lack of data. There's a lot of data that is missing. And I'm going to finish on this because it's really important. I keep going on about social determinants of health, but we also need to gather data on sociodemographics. And we are very, very poor at this. We recently looked at the existing data on randomized controlled trials, which are the gold standard level of study we can have in science. And even in randomized controlled trials for infectious diseases, we are very poor at defining demographics of populations. We are good with reporting on male, female, so sex and gender in relation to the population, but we are very poor at capturing other factors that influence, for example, ethnicity, status, access to education, socioeconomic status of trial participants, so that the evidence we generate that decides the interventions we develop needs to be representative of the populations in which these interventions are going to work. And we're not doing that currently. So the work that we are doing with India and South Africa currently is to take an intersectional lens, working with communities in South Africa and India to understand how access is compromised based on intersectional identities, but also how we can leverage these the power that we have within the community to develop interventions that are more likely to be taken up. And a lot of this comes back to roles and responsibilities and experience, the lived experience of individuals, looking at team dynamics within the hospital settings, but also at from the patient and care engagement, looking at access to resources within community as well as within the healthcare system. And there is a role for policy in this. There is a very big role for policy. I'm glad that one of the previous speakers spoke into the addressing gender inequalities in national action plans. This is something that we really need to take seriously about equitable representation and voice and advocacy in policies. I don't want to go over my time, so I'm going to stop here because I know there are other speakers also who are going to contribute to this conversation. Thank you.
Thank you, Esmita. And really a very, very impressive way where you have spoken about social determinants of health and the power factor that comes into play, and women having the least power to negotiate, whether they are healthcare workers or outside of the healthcare system. Thank you very much, Esmita. And I just wanted to say one thing. If we remove the E from your name, the first letter, then Smita is a very Indian name.
My name is Indian. My name was chosen by an Indian colleague of my dad. So I have an Indian name.
Okay, okay. Thank you very much. And thank you for also talking about importance of data and disaggregated data, which Dr. Soumya also mentioned, which is always lacking. Thank you very much. Now we have another expert who is widely recognized for her contribution to WHO guidance on AMR and gender inequalities. I invite Dr. Deepshikha Batheja, Principal Research Scientist, Indian School of Business, and Visiting Fellow at One Health Trust, to share with us India and Asia Pacific regional perspective on AMR and gender inequalities. Welcome, Deepshikha.
Thank you so much, Shobha and CNS, for organizing this. I am a researcher and an economist, so I'm going to use slides because I want to show some numbers building on what my previous speakers and my colleague Esmita was also saying. But before I start, I was hoping that Sara would be here from the WHO, but the effort was led by Anand Balachandran, who is here. I think it's a very important policy brief on addressing gender inequities in AMR by the WHO. So it's there in the chat. So please do refer to that while doing your own work, or while preparing your own national action plans or state action plans. So I think there has been enough motivation on this topic. But what I can say here is that when we think of AMR, we think of microbes mostly, or bacteria, but it is really a human decision problem, human decision-making problem when we think of antimicrobial usage, which is the community driver of AMR, which is related to over-the-counter use or self-medication of antibiotics. So it is a human decision-making issue. Even IPC and WASH in hospital stewardship, it is dependent on human decisions. Even at home, women are the ones doing all the care work. So, and the decision to buy antibiotics is also a human decision. So, and the decision by the farmers to buy antibiotics for their farm or poultry, livestock, is also human decision making, which is a result of the information that they have, their own behaviors, the budget constraint or the resources that they possess, the time constraint. And all of this is impacted by gender. So gender is a key social determinant of health as well, and of antimicrobial usage also. And in hospitals also, IPC is mostly in the hands of nurses, who are mostly women. In the community health, the community health workforce is also constituting more of women. So I think gender is a very key important issue when we think of AMR, key and important issue. And we have laid out the linkages in this BMJ Global Health paper which was published in collaboration with Shrishti Goel from One Health Trust and Esmita Charani, Dr. Esmita Charani. So you can look at these linkages that have been laid out by my previous speakers, but it's also here in this paper. And as building on what Shobha was saying, we've also spoken about and laid out this conceptual framework which links social norms, social cultural norms, and AMR. So there are norms around menstruation, caregiving responsibilities, and this is mostly in lieu of people in low and middle income countries, but it's also applicable to other settings. Norms around what kind of jobs are suitable for women. Then there are norms around sun preference, physical mobility, restricting women's physical mobility, norms around pregnancy and control and ownership of financial assets. There are gender biased health systems. All of them lead to reduced access to WASH. They define women's nature of paid and unpaid work, the caregiving aspect of unpaid work. That leads to lower education and awareness amongst women and prohibits women and girls from seeking healthcare freely. And all of this also impacts the intermediary drivers of AMR, which increases susceptibility of infection among girls and women. It reduces the health-seeking behavior and ability to seek and afford essential antibiotics and quality healthcare, and leads to inappropriate diagnosis and management by healthcare providers, which in turn impacts AMR outcomes of inadequate access to essential antibiotics, lack of appropriate diagnosis, and leads to increased antibiotic intake and increased AMR. So we've also cited the literature connecting these themes and these norms to these intermediary and AMR outcomes. So you can look at this paper if you're interested. We also have done some work. We started off with the data from the high income setting of the United States. And we found using county level data from IQVIA for 2019, we find that women are prescribed 34% more antibiotics compared to men. And even when we take out UTI medication, CDC has guidelines on which antibiotics should be provided for UTI. So we took out those antibiotics and we still find that women were prescribed 31% more antibiotics than men. So this got us really interested and we started looking at the disparities in states. So this is just descriptive evidence. And if you see here across all the states in the United States, we find that women are prescribed 30 to 40% more antibiotics than men. And in some cases, even 50% more antibiotics than men. Then we wanted to look at other intersectionality with gender. We wanted to look at race, which is a prominent social determinant of health in the United States. And we found that areas with above average minority population, so above average non-white population, had much higher antibiotic usage than areas with below average minority population. But the gender gap still remained. And when we looked across age groups, we found that boys and girls started out with similar antibiotic intake rates, but it really diverged, especially in the reproductive years. Then we also thought that why not link these antibiotic usage data and see if gender equality is associated with these. So this paper we published, got recently published in Journal of Antimicrobial Chemotherapy, where we use IQVIA data from 70 plus countries for 2 decades. And this is yearly data on antibiotic use in a country. And we find that when we connected it with the indicators of gender equality, but the data on antibiotic use is not disaggregated by sex. It's only the gender equality indicators that we associate with the total overall antibiotic use. And we find that a 1% increase in women's education and a 1% increase in female to male labor force participation, which is reduction in gender workforce participation rates, gender gaps, we find that it leads to around 12.81 lower antibiotic consumption in the country. And this is within country and across countries as well. We do not find anything for women's parliamentary representation and its association with antibiotic consumption. But this does provide evidence that that effective stewardship, antibiotic stewardship policies must go beyond health systems, and gender responsive policies, especially expanding women's education, women's economic participation and empowerment, they could also lead to reducing inappropriate antimicrobial usage. So you can look at this study as well. And this we have another study. So we're trying to go local, and we because One Health Trust is also based in Chikbalapur in Karnataka. We did a survey of around 1,000 households in rural and semi-urban Karnataka, Chikbalapur district, and we find here that men have higher knowledge of antibiotics and AMR. In general, the knowledge is really poor. It's around 3 to 8%. And knowledge of antibiotics is around 10 to 22%. But you can see there's a huge discrepancy in the knowledge of antibiotics among men and women. And more men also reported about obtaining information about antibiotics from doctors. It could be that they could be accessing it more. So around 26% of men reported to have knowledge about antibiotics because of the doctors, but only 19% women reported so. And there were, of course, higher symptoms of UTI and among women, more caregiving responsibilities among women. And we looked at other outcomes as well. This paper is still we are still working on it, but I thought I'll show you some descriptive, evidence that we have from this region. Yeah, and then self-medication rates also, this is self-reported, and they say that this is on antibiotics, but the knowledge is also poor, so it could be related to that. So we've also conducted some responsive dialogue meetings in the first one was in Bangalore with Esmita from University of Cape Town, Tasha from EWOSA. And this was in Bangalore, a 2-day meeting where we looked at the linkages between gender, caste, climate change, and AMR. We also had another workshop in London last year, where we invited people, policymakers, WHO officials, and researchers. So the idea was of these responsive dialogues meetings was to recommend that GAP 2.0, Global Action Plan 2.0, includes gender and equity commitments in the revised plan. So you can read this as well. But some of the recommendations that we came up with for different pillars I'll get to this, and this is my last slide. But before that, I would just like to say that I have seen GAP 2.0, and it unfortunately does not mention gender. It does mention data collected by sex and other social determinants. But however, it does include equity, especially in relation to preventive care, research, diagnostics. So it does include equity. So that's something that we take. The efforts that we have been making as a group for years, something has come out of that. So this is the recommendation, so I'll go through this. So the first one that we say, and you can use it in your research, in your, when you create your states, if you contribute to your state's action plan on AMR, you can please feel free to use these recommendations. They are across different pillars. The first one is on communication, and we suggested that there should be co-creation of locally tested and context-specific AMR messages, languages, images to address gender norms and promote health equity. And then about data, we've talked about surveillance and research, and we've recommended that we adapt country-level methods and data collection protocols for antimicrobial usage and surveillance to include disaggregation by sex, age, and other priority social stratifiers related to that country's vulnerable population and inequity. We also talked about infection prevention and WASH, and we've recommended that we generate evidence on the needs of population and test interventions to improve equitable access to immunization, IPC WASH in health facilities and community settings. And then this is about the over-the-counter use of antibiotics and self-medication. So optimizing the use of antimicrobials in humans and animal health, we need to generate evidence to identify populations receiving these unnecessary antibiotic prescriptions and uncover any unconscious bias in physicians' prescribing practices related to gender, socioeconomic factors, and tailor stewardship actions to address such biases. And also understand the factors that influence self-medication rates. And for governance, we have recommended that we involve gender and equity experts along with representatives of vulnerable or marginalized groups in multi-sectoral AMR coordination. And we believe that indigenous knowledge from the community can actually help design alternate solutions to AMR. And we've also looked at the National Action Plan 2.0 from India. And unfortunately, that also does not include gender and equity concerns. It does mention that the data and surveillance on AMR should be disaggregated by sex, location, and other factors. And India has also several states have come up with their state action plans, and community awareness is a huge part of it. So which kind of ties into what we have been talking about, that people should have right to information on AMR. People should know about this issue so that they can make their own decisions wisely. Thank you.
Thank you very much, Deepshikha, and very interesting data from your studies. We hope that policymakers take note of them and include that in NAP. As you said, that is not, you have seen that and it is not there. So let us hope for better policy making and administration. Thank you very much. I now invite an inspiring youth leader, Dr. Salman Khan. Salman is a former member of Quadripartite Working Group on Youth Engagement for AMR and a youth engagement consultant at React Asia Pacific. Over to you, Salman. And yes, we are not confusing you with the film hero Salman Khan.
Thank you so much for the clarification. It's often needed in many spaces. I hope all of you are doing great and are safe. Thank you for this opportunity for me to speak on behalf of React, as well as a lot of my youth peers. Just to give you an overview, I will structure my remarks for this panel discussion around three clear questions. Why youth engagement and gender inclusion? What and the how? As a young expert and an advocate who recently graduated med school, I sort of bring a perspective that is often invisible, but it's crucial, which is the lived realities of youth and especially young women and marginalized genders who operate at the intersurface of animal health, human health, environment, agriculture, as well as community systems. My plea is simple to all of you. Listen to youth as agents of change and let their lived experience also inform policy. And as we talked about very briefly in the starting of this panel discussion, patriarchy plays a central role here. Patriarchal systems still concentrate decision-making power among older men while positioning youth, especially young women and gender-diverse communities, as beneficiaries rather than contributors. And that sort of translates in AMR governance, where policies are designed about young people and not with young people, despite the fact that the youth are deeply embedded in the world health, in the One Health systems, be it your households, your farms, your clinics, schools, markets, and ecosystems. And a friend of mine told me if AMR is a crisis, then youth happen to be its early warning systems, as well as its long-term risk bearers, as well as one of the key solutions that are often overlooked. So I'll move to the why youth in general, gender must be central to AMR. Often, a lot of our peers frame AMR as a technical problem where microbes evolve, drugs fail, antimicrobial pipelines dry up. But AMR is also deeply social. It's shaped by who has power, whose health is prioritized, who controls resources, and whose voices are ultimately heard in decision making. So it's a social and development crisis that shapes lives, livelihoods, and economies for decades. And young people are currently inheriting and will inherit both the problem and the consequences. Yet we remain underrepresented in the rooms where decisions are made. So according to the IPU, about 2.5 to 2.6% of parliamentarians are under the age of 30. And not as a shock of fewer than 1% are young women. This gap matters because when policies are shaped without youth perspectives, they will miss social realities that drive antimicrobial use and resistance. Yet the numbers of the rest of less political representation do not tell you the whole story. There was this survey called Be Seen, Be Heard Global Youth Survey, supported by the UN Office of the Youth Envoy, and that showed that around more than 65% of the people believe in a better future. with 15 to 17-year-olds being the most optimistic out of all age groups. And mind you, this optimism is not naive, it's a resource. In the fight against AMR, young people not only bring the urgency shaped by the alarming data, but also hope, creativity, and the belief that the systems that we currently have can change. So beyond the harrowing statistics we often see related to AMR, it is the optimism that enables the youth to imagine and build AMR solutions that are preventive, equitable, and future oriented. Um, with this, I'll briefly touch upon reverse ageism, which I also have experienced in personal capacity. Uh, it's the tendency to assume that the legitimacy and insight flow only from older age. So this systematically silences young voices and substitutes our lived experiences and expertise. And this eventually weakens policy relevance and undermines the implementation too. So moving on to what are we missing? The very first key takeaway is that the youth are central to One Health, but are excluded from the governance, which was quite obvious from the points I mentioned above. Thankfully, in 2022, the UN's Quadripartite formally identified youth as a priority audience, and subsequently, a global youth manifesto was co-created with multiple youth advocates across the world. And this manifesto urges the governments and the health policymakers to include young people, especially young women, on AMR policy bodies and educational initiatives. In short, we must be empowered as stakeholders in AMR solutions, and recognition without structural inclusion is not enough. As it's been time and again highlighted by all the excellent speakers on this panel, gender norms and patriarchy do create asymmetrical risks. Young women often face higher exposure and constrained access to care. Educational gaps that's sadly happening in a lot of countries as we speak. Restricted mobility, caregiving burdens, and limited financial control all shape antibiotic and antimicrobial use and risks. Young men sort of face different vulnerabilities thanks to toxic masculinity and social norms that discourage even care seeking, and that encourages risky behaviors that can ultimately increase the infection burden. And gender minorities, as in the LGBTQIA plus peers, face stigma that deters care altogether. And as an analysis from React underscores, tackling AMR requires us asking how sex and gender relate to AMR and how gender shapes behaviors and responses. Um, Last but not least, about the why is when I was a part of the Quadripartite Working Group on Youth Engagement on AMR, while we were working on the Youth Manifesto, we had global consultations with young people. We were able to understand, and they also highlighted how poverty, gender, intersectionality, power and emergency conditions together exacerbate AMR challenges for the youth. Let me give you a very simple example. Let's say an adolescent girl in a rural area who belongs to the lower income strata may or may not have school health program on responsible antimicrobial use, may face poor sanitation, and family norms might lead to deprioritizing her clinical visits. In contrast, let's compare it with the wealthier cis heterosexual person or man in a city who might have better health access, but might engage in risky behaviors like tobacco consumption, unprotected sexual intercourse, or even self-medicate. So my key takeaway here is, without an intersectional approach that considers these overlapping factors, interventions will miss our groups, which is why it's important, which is also highlighted by the previous speakers, to have disaggregated data by age, sex, region, and tailored policies. And failing to do so is going to again exacerbate inequalities. So the how, or the tips that I have as a youth advocate on behalf of React, is the first being institutionalized meaningful youth representation. We are working on analyzing the national action plans, and they sadly, the national action plans currently still view youth as beneficiaries rather than equal partners or stakeholders. So this unidirectional relationship needs to change. This paternalistic relationship between, AMR interventions and youth. Sort of needs to change. The dynamic needs to flip at some point. And AMR, since we all know, is an inherently cross-sectoral issue. So youth involvement must also be cross-sectoral. So governments should perhaps create a national youth One Health Council on AMR that can bring together young voices from not only hospitals but also farms, schools, and NGOs to advise AMR programs. But let's not forget, we youth still often face tokenism in some way or form. And to move beyond tokenism, youth participation must be structural and empowered and not symbolic, which means mandating youth seats with real decision making power on AMR communities, responding formally to youth recommendations. Crucially, these forums must be accessible to all youth and even children for that matter, providing childcare for young mothers or travel support so that disabled youth can also participate, hold meetings in local languages, and even provide safe spaces so that our LGBTQIA plus folks feel included, create child sensitive and accessibility aware policies, and last but not least, cross learning exchanges that would link rural peers with urban peers, and that will sort of foster mutual understanding on how all of these sectors connect so intricately. And representation at the end must be diverse. It should be rotating and transparent so that youth are not just present for the optics, but positioned to shape priorities, budgets, and also outcomes. Um, I touched upon reverse ageism earlier while I was speaking. So we need to train young people in advocacy and policy analysis, equipping them to contribute to national, AMR strategy reviews and represent them in conferences. Mentorship schemes pairing youth with AMR policymakers can reverse this gap of reverse ageism. And most importantly, public health messaging, which we see all across now, should treat youth as equal partners. Recognize that an AMR savvy teenager who might be doom scrolling on Instagram, working their way around the TikTok algorithm, can be just as convincing to families as a distant expert on AMR. So we must fund youth created content, whether radio dramas by teenage creators or even TikTok campaigns by medical students for that matter, since peer voices do resonate when official campaigns may not. And last but not least, we really need to move beyond the gender sensitive band-aids which we still apply, because they don't address the root causes of inequality and inequity. Gender transformative work tackles root causes. It talks about redistributing resources, challenging norms, and changing power relations. Practical measures should include empowerment. And one such examples that my colleagues from React Asia Pacific are doing is the Antibiotic Smart Community project in the urban slums of Delhi in India, where we are working with women to build community champions and educators. And by centering women as change makers, the project is shifting household norms and creating local networks led by young women. Um I touched upon education as well, that being a very paternalistic relationship. So here we need to develop AMR curricula together with young people so that content resonates with their concerns. Schools and university health programs should cover both general AMR knowledge as well as gender specific topics, including sexual and reproductive health and rights, menstrual hygiene, antimicrobial use. UNESCO and WHO have done an incredible work on recommending how to involve youth in designing such materials. And even early scientific studies show that youth targeted interventions can significantly improve antimicrobial knowledge among adolescents. If you're more interested, you should read the Antimicrobial Resistance Toolkit for Youth Engagement by the Quadripartite, which is easily available on the net as well. My closing call to action f- would rather be this analogy, AMR without youth and gender is more or less like an orchestra without percussion. it's incomplete, it's out of rhythm. So you really need to empower youth and embed gender justice here. And again, the quadripartite and the civil society, thankfully, are beginning to listen. And now we must transform this listening into power, resources, and institutional change. I'll give you a short gift from our side. And if you're wondering what you can do more to meaningfully engage youth, I encourage you to go through the youth engagement section of the React toolbox that's developed by us. I'm sending the link on the chat box as well. It covers how to engage youth meaningfully in AMR initiatives, what are the common challenges, and what are the strategies to assess the status of youth engagement. So, again, youth are not the future stakeholders, we are the present actors too. So, thank you so much for giving me the floor.
Thank you, Salman. And we have full faith in the youth power, and we hope that you will be able to disband patriarchy and replace it with a feminist response to tackle AMR. Thank you very much. And last but not the least, we have a special guest with us from Jordan, Dr. Maisam Akroush. She is founding president of the Pan Arab Women Physicians Association and part-time lecturer at the Medical School, University of Jordan. Welcome, Dr. Akroush. We are all very concerned with what is happening in your part of the world, which is also our part of the world. And we hope that peace and sanity prevails. Meanwhile, we are keen to hear from you your plan for preparing for community protection awareness activities with youth in communities. I
Yes.
think that is going to gel with Salman a lot.
Yes. Good day, everybody, distinguished colleagues. It's an honor to join this crucial discussion on antimicrobial resistance, a challenge I have worked to elevate both at the policy level and within the community. Actually, AMR is not only a microbiological threat, it's a system and behavioral challenge. So in Jordan, it's been a national AMR strategy emerging from years of the WHO-led multi-sectoral coordination. It was aligned with the Global Action Plan. I was honored to contribute to these structural national efforts as a representative of the Jordan Medical Association, among so many other institutions in Jordan, supporting the stewardship and regulatory reform. Most recently, maybe some of you had heard that the female leadership of the Jordanian Food and Drug Administration, she enforced prescription only antibiotics dispensing, a landmark decision, but it moved the street. So there was some reaction. It revealed a fundamental truth. Regulation alone cannot undo decades of habits and mindset. Behavioral change must accompany policies. And in a minute, I will talk about how we are working on that as well. Actually, this understanding shaped the work beyond national, the strategy, where we had through founding the Pan Arab Women Physicians Association 3 years ago, and along 5 of the conferences that we organized, we had an initiative called an ounce of prevention is worth a pound of cure, and always AMR was in the core of this awareness campaign, where we had guests from infectious disease communities. We had local and international collaboration with WHO, with the Royal Colleges of Physicians, and local institutions to talk about how dangerous the resistance that's issued because of irrational use of antibiotics to the public. And we were the first to have the public on board with us in these campaigns. Talking about women, I heard that everybody spoke about women as a victim of irrational antibiotic use, and how their infections, their diseases, and their violence against them in the community led to their resistance issue being dangerous. But now Actually, I will talk about women's role in combating irrational antibiotic use. Women as the head of the pyramid and very important part of the equation. They are the mothers, they are the leaders, they are the teachers, they are the prescribing doctors, and the women in the pharmacy who will sell the product. So they are at a great position to lead the change on antibiotic irrational use. A mother might be in a hurry to recover. So she might need to buy the antibiotic for herself when she is sick to be able to carry her responsibilities towards her family and her family members and her work as well. But as a mother, she is also the decision maker for her child's health, whether to give or not to give the antibiotic. She might be the one and the only one who can change the mindset of the youth on using antibiotics for their health. So she should be the targeted person in our campaigns where we might educate women and then get a whole population educated on how, when, and whether to use antibiotics or not. So preventive medicine always plays the pivotal role in preventing complications. I believe women as caregivers, as educators, and decision makers, they can be our targeted audience for any campaign. So we won this youth empowerment initiative by the Trinity Challenge, who are related in a way to Oxford University in the UK and supported by the WHO of the world, as one of the proposals, one of 7, which won out of 182 worldwide, where the youth will lead the campaign, their word of mouth in different ways, using the media, using their knowledge, going as ambassadors for their colleges and all the faculties of medicine in Jordan, using them in their private hospitals and the government and military institutions in Jordan. They will run such a prestigious campaign, educating people using AI, using all the technologies, using the influencers of the community. As you all know, social behavioral change will change the world towards what we are aiming at. Because what we had as a culture for years and years and decades can only be changed by the great power of the new generations. We have to start from the base of the pyramid, where the youth are the main concrete. And our team is not less than 100 beautiful young males and females, doctors, medical students, and pharmaceutical students. And we have already gained the trust and the support of most of the Jordanian health institutions, and they will start educating the public. We reach out through our initiative, an ounce of prevention is worth a pound of a cure, run by the women physicians of Jordan, to all the remote areas, all the areas and governance of Jordan away from the center. We educate in schools, we educate in camps, we educate even refugees in Jordan. You know, we have a lot of refugees for Jordan, being the host for all sisters and brothers from the countries affected by conflict and natural disasters in the area. So we reach out to everybody. Humans are humans to Jordanians. We don't differentiate, and there is no bias to Jordanians from others, but we reach out to everybody. We educate them on the use of antimicrobials, on how essential it should be advised by a physician, and we're aiming at guidelines even for physicians, because every one of us knows not every physician knows when to prescribe and when to hold prescription on infections which might be viral, and we need to set an objective guidelines to when to use antibiotics. We'll use AI and digital games. We'll use the screens in the streets, and we have word of mouth via influencers to help. So I see myself talking the last, but I see that I benefit a lot from all my colleagues who spoke before. Their experience is tremendous, and I'm happy to, I copied actually most of the links to help our campaign find its way through national and international experiences that we are proud of. And this collaboration will make a difference, I hope, in the local place, Jordan, but will be spread to the Arab world, as we are a pan-Arab women's physicians association that are holding the same flag for combating all the health pandemics that we are suffering from in the area. I believe so women are central to this transformation as prescribers, caregivers, as we said, mothers, educators, and community influencers. You know, in Jordan, we have so many women's heads of some health institutions. And this is proudly, I say, a revolution that occurred after we started the Jordanian Women Physicians Association, growing up to become pan-Arab. So because of the habits of today's child, they determine the resistance patterns of tomorrow's hospitals and elderly. So the fight against antimicrobial resistance is not only scientific, it should be social, educational, integrational, and women are at its center for the time being and any time to come. Thank you.
Thank you very much. Thank you, Maisam. And you spoke the last, but not the least at all. And yes, and all force and power to you for your efforts of mobilizing youth, and also for mentioning that women should be at the center of response and should be targeted to educate society in driving AMR responses. Thank you for sharing such great insights. Thank you very much, Maisam.
I thank you much, and I thank WHO of Jordan, represented by Dr. Laura, who gave me this opportunity, although the last minute, but I think our voices are always together for a change and the great change.
Yes, all force to women power. We now open for questions and comments from the participants. We have a few questions already, and we also have some great people in our audience. We have with us Rita Vidyadana. We have Kalpana Acharya from Nepal, Rita from Indonesia, Ojoma from Nigeria. Would any of you like to add something or speak something on the topic today? Can you please raise your hand?
Yes, Shobha.
Yes, Kalpana. Yes.
Hi, everyone. I'm Kalpana from Nepal. I'm the member of Global AMR Media Alliance, also the chair of South Asia Pacific region. I just want to know, I don't have many questions, but this session is very interesting and very fruitful for us, for media persons like me, because one of the research, I think that research from Deepshikha, very interesting research, 34% antibiotics prescribed for women more than men. So this is very interesting for media persons like me. Definitely, I will cover this line in Nepal's media fraternity, and I will also raise this issue. So we are trying to aware the people of Nepal on AMR, especially antibiotics misuse and overuse and over-the-counter selling. So we media persons are making a network of antibiotic awareness network. So This is a very interesting session for me. Thank you, all the speakers. Really grateful. Thank you.
Thank you, Kalpana. Rita Vidyadana from Indonesia. Would you like to say something? And Ojoma Okor from Nigeria. I know you are en route to Kenya right now, but if you want to add something or say. All right, while Rita and Ojoma decide, we have questions. We have a question for Soumya from Rashmi Ratna. She says in most of the STI cases, women do not want to seek help from medical practitioners initially and use medicine by self-prescription or from pharmacies. How can we address such practices? Soumya, if you're there.
Yes.
Yes, please.
So I think this is a complex societal issue, again, related to, we talked about, I think many of the speakers have mentioned issues related to stigma and other barriers to access. But using women's groups, I think there are so many self-help groups and other kind of community groups across all our countries. These health issues should be discussed. Generally, these groups are set up for livelihood related matters. But if you really talk to the women, they actually appreciate it if you get into a health discussion with them and they come out with these kind of problems which they are otherwise not able to share with anyone. And today, using digital tools and telemedicine, you can actually communicate with these groups. We've done that also through our foundation, through these women's groups on a fixed day time each week or something like that, where they can talk about these issues, get examples, and build their own health literacy as well. So there really needs to be, apart from a top-down kind of messaging, which often doesn't reach the target, I think these kind of peer conversations and with people they trust and they know, like their own frontline health workers. So I think we have to also equip our ASHAs and ANMs and so on to discuss these issues with women whom they may be seeing for other, like a pregnancy or something like that. But I think we miss the opportunity to bring up some of these topics.
Thank you. Soumya, another question for you from Kalpana Acharya of Nepal. What role can media play in addressing gender inequality and antibiotic misuse? For example, in case of UTIs and other diseases.
I think the media can play a very important role overall in antibiotic misuse. As part of that, the gender issues could be highlighted, but I think it's just so widespread in the community that we need to tell many more stories. You know, as some of the speakers were saying, we need to tell the stories of what happens when there is a misuse of antibiotics. And it could happen to you or to a loved one as well. So I think people don't quite realize the implications. And I think doctors also unnecessarily overprescribed antibiotics rather than wait and try and make a proper diagnosis. So I think across this thing we need more education. We need much more data also, like Deepshikha was showing. I think those kind of data coming out of surveys, I think helps to bring it home to people.
Yes.
Thanks.
Right. Thank you. Thank you. There's a question for Bhakti from Kavita Upadhyay. Kavita wants to know, Bhakti, do you see impact of greater engagement of AMR survivors, especially women, in controlling AMR?
Yes, I believe the inclusion of patient survivors' voice is very important, especially women. So when I was diagnosed with the drug-resistant tuberculosis, I was completely unaware about this drug-resistance strains, about the treatment. But there is a active TB group in India where majority of women who already shared their stories in the public domain. I read their stories which gave me so much of strength to complete my treatment. these women are, providing the help. They create a awareness as well as they are doing the patient advocacy. So I reached to them throughout the social media, and I used to share my side effects with them. And then these stories are really important, that TB is very curable disease, and if you complete your treatment, you'll get cured. So these patient stories are really important, and supporting, advocating for that is also equally important.
All right, thank you. Thank you, Bhakti. There is a question for Esmita from Annabelle. Dr. Esmita, can you explain how female health workers are being supported and protected given their frontline roles and potential occupational exposure to resistant infections?
Thank you for the question. I think this is a very important question, but it has to be nuanced to different contexts and different cadre of healthcare workers. So one of the issues we had was, for example, during PPE, when a lot of the personal protective equipment was made a one-size-fits-all and often wouldn't fit female healthcare workers as well as it would men, and there were issues around that. The other thing to bear in mind is often, if you look at the nursing cadre, the majority are female. And we have to ask whether in different settings where resources are compromised, are we protecting our healthcare workforce adequately against transmission of infections? For example, in the hospital where I work right now in Cape Town, I work in a government hospital, and having TB masks the correct masks is very difficult to obtain. So people are reusing their masks. Now, this isn't gendered. This is the reality of working in resource-limited settings. But the majority of the healthcare workforce that are being exposed to this by default are female, because it is nurses who look after the patients. And the nursing cadre by default is predominantly female. So I think we need to understand the risks associated with occupational risks associated in communicable diseases, and how that may be impacting people from different backgrounds, different socioeconomic backgrounds, different gender, different professions, and what we need to do about that. We have conducted a study looking at existing evidence of power and how it manifests in healthcare setting. And although there are disappointingly and overwhelmingly negative examples of how power is impacting women differently to men, whether it's within the healthcare workforce or between the patient and the healthcare worker, there are promising examples of where power is being leveraged for good. And this is where we co-design and co-develop interventions, whether it's for healthcare workforce or for the community members, with their participation and with an understanding of what their needs are, rather than often what we do in healthcare is we have an intervention or a solution that is looking for a problem. And that is the wrong way we go about healthcare. And we do the same in AMR space with, here's a new antibiotic, here's a new diagnostic. And we try to give that to everybody without understanding how will this work in the context or the setting in which it is expected to be taken up. So I know I haven't answered your question properly, because there isn't that much evidence about what we are doing right, but there is a lot of evidence about where we could do better. And I think that's where we need to focus our attention. Thank you.
Thank you, Esmita. There is a question for Deepshikha. Thanks for sharing strong data on AMR and gender. Qualitative data is also there, which is data with the soul. The question is, are national action plans on AMR or sub-national action plans rooted or shaped by data on an ongoing basis as more evidence comes in? For example, are programs addressing AMR with One Health approach and gender inequality converging, synergizing?
Thank you for the question. The issue with the National Action Plan and the state action plans are that they are not very well funded. So there are plans and there is an intention. So they've taken the One Health approach, involving various departments, One Health departments, which are more than 15, 16 departments. So they have, consolidated them and prepared this, with consultation. But there is not much funding for AMR mitigation strategies. And forget about testing these strategies. Whether they actually reduce the burden of AMR or perpetuate existing inequities. So we really need to test these solutions and interventions. The problem also is of our healthcare spending, especially in India, we're spending 1.3%. Max to max of our GDP on healthcare, and there's so much of underutilized funds. In health. So the issue is that even though some of the states like Kerala, Madhya Pradesh, Delhi, Andhra Pradesh, Gujarat, Sikkim, and Punjab, they have created this state action plans to mitigate AMR, but it's mostly on paper. With an exception of Kerala. Kerala is doing very well, and they have come up with a lot of policies, AMR smart communities, and they have Gujarat and Kerala have also banned over-the counter sales of antibiotics. But we haven't had any impact assessments or evidence on the effectiveness of these policies. So I think we really need more evidence, to see what policies work and in which context. Thank you.
There's a question from Lakshmikant Chavan that which specific key drivers of AMR can be addressed through gender and equity lens? Any specifics from India studies and experience? Deepshikha, would you like to comment on that?
I've mentioned the low-hanging fruit of IPC and hygiene. It looks easy. It is, most people believe that AMR is coming from hospitals. So let's work on that. Let's train our nurses. Let's look at waste management. So I've mentioned IPC, but WASH is a big one as well. And vaccinations, not just for humans, but also because there's enough evidence generated by One Health Trust, the team, that vaccines for humans is important, but for animals also only 12 to 13% of the vaccinations are only 12 to 13% for various diseases. So I think there should be awareness on and encouragement on the use of these vaccines. Thank you. So prevention, as Anand was also mentioning, prevention is important.
Thank you. Yes. Anand, would you like to please say out your comments loudly, because we have this on YouTube also. This session is being live streamed on YouTube. So would you please like to speak?
Sure. Thank you. Thank you, Shobha. This is Anand Balachandran. I used to lead the AMR National Action Plan unit at WHO headquarters, and now I've separated from WHO, but still a big AMR supporter. One thing I would like to highlight, given this discussion on inequalities and addressing inequities, is that we really need to also reach out to the health systems teams at all levels, at local, national, global levels, because ultimately AMR efforts in terms of prevention, diagnosis, treatment, and care should be part of the package of primary health care to achieve universal health coverage. So and that's where government policies are being made to to achieve universal health coverage. So we need to make sure that our AMR efforts are well embedded into those health system strengthening efforts. I think those are when we did a lot of work on addressing equity and AMR, the systemic challenges are really both upstream indicators, and also in terms of accessibility and coverage and availability, etc., really play a big role. So in order to have a big impact on AMR, we need to address some of these systemic challenges as well. And for that, we need a bigger community to help us. It can't be just the AMR community. We need to also reach out and increase awareness among other human health silos. Unfortunately, we are still in silos, and we need to reach out across these silos to have a bigger impact. But gathering evidence is the first bit, and so I'm really happy about this discussion today, focused on gender inequalities, and I hope you will have another discussion on broader equity issues that impact AMR as well, not only in the human health sector, but in the animal health and agriculture sector as well. So thank you again. This was fantastic. Thank you.
Thank you, Anand. Thank you very much, and thank you for guidance and comment. And yes, we will definitely try to do that next time. Definitely. There is a question for Salman. Salman, the comment is, thanks Salman, our Prevent AMR real hero. Very important presentation on youth engagement today for a better tomorrow. Are more youth, especially young women and girls and other gender diverse communities and marginalized communities, joining youth groups around AMR? We need to listen to most underserved youths. Can you please comment on that?
Yes, of course. They are joining youth groups, and they are also, tackling AMR-related health issues like WASH, climate change. I would personally comment that there's still some sort of siloing in the youth groups going on, which sort of needs, a direction. And that's where, all of us come in, and, it's important to highlight the One Health aspect of EMR here. We have excellent examples. That is the Quadripartite Working Group on Youth Engagement on AMR that convenes, organizations across different disciplines, and also there is a diverse representation of local, national, and international organizations too. And even us in REACT, we have the Africa Youth Task Force, and we recently came up with the Asia Pacific Youth Engagement Task Force as well. There is a bit of fragmentation, in my personal opinion, but we are still getting there. It's much more steady compared to a lot of other things that are happening in the youth space.
Okay, thank you. There is a question from Jack Barber, that how can AMR research benefit from sustained engagement with gender studies and other related critical disciplines? How might we avoid reinventing the wheel by failing to connect work on gender in the AMR sphere to wider study of power, patriarchy, and gendered oppression? Would any or all of the speakers like to respond to this, or any of the speakers?
Shobha, can I say something on that?
Yes, please.
So this is why it's really important to not fall into silos and look at gender alone in any aspect of work, but specifically in relation to communicable diseases and disease and health generally. And I think that is why it's important to bring this conversation about inequities that we see in data, in inadequacies we see in response from policy, in health systems management, that is highlighting how women versus men may be experiencing the system differently, but also look at how this links to other social determinants of health. It's not just women versus men, it's also about socioeconomic differences, it's about migration status, it's about race and caste and ethnicity. So it all comes together. And I think that is something that we have to keep in mind. And the other thing is, we talk about gender inequity, we also have to look at men as well as women and their health needs and the data gaps in both populations. So I completely agree with Jack Barber about this point, but it is encouraging to start to have these conversations, because unless we identify what the gaps are by individual indicators, we can't bring them together and cluster them together and look at the composite impact of all of them on the impact of health and healthcare needs of different populations. So yes, it is important not to work in silos, but we do need to look at these indicators individually to see where the gaps are, and then to bring them together to see how, on the whole, from an intersectional lens, how individuals may be impacted by this.
Thank you. Thank you, Esmita.
I want to add one thing as well.
Yes, please.
I think we in our workshops have involved people, from who have worked on gender. So to include feminist perspectives, we are doing a workshop on 10th March in ISB to incorporate caste perspectives and link them with AMR. So even though people and community-based organizations who are working on gender and caste, they don't know about AMR, we first, we bring them together in a room and do a workshop where we educate them on this issue, and then, learn from them about their perspectives. So we have been doing that, and we have been formulating linkages between these based on the already existing body of knowledge, the vast body of knowledge. Thank you.
Thank you, Deepshikha. Now, I think we have already overcrossed the time by several minutes. So with this, we come to the close of today's session on the theme of AMR under gender lens. My sincere thanks to all our speakers for unwrapping the subtle and often ignored nuances of how gender influences people's exposure to infections, and women and girls face higher barriers in accessing healthcare, making them more vulnerable to complications from drug-resistant infections. Thanks to our audience for their very active participation. And I invite you all to join us on March 10 in the She and Rights session hosted by Force Feminista, Women's Rights Caucus, and CNS to know about the outcomes and analysis of CSW 70. Till then, goodbye and namaste, and let us all pray for peace and sanity in today's tormented world ravaged by military action. Thank you for all your presence and help and cooperation.